Oh,
Okay, we are now formally recording.
awesome. Thank you. Okay, let's do a round of introductions. I think some people have already introduced themselves. If you could share your name, your pronouns if you'd like to, and in what role are you here today? As a member of the committee, member of the public, AMH, any relevant hats that you're bringing to the table. So I'll go first. My name is Malaika. I use she, her pronouns. I'm a member of the committee and I manage peer support services for HCRS.
I'm Thelma. I'm a member of the committee. I work for the Counseling Service of Addison County as a peer recovery facilitator. And she, her.
Go ahead.
Ward or Dan?
All right, this is Ward. I'm a member of the committee and just a general activist and advocate for folks with diagnosis.
This is Dan
Toll,
a member of the committee. He, him, Pathways Vermont operator and mental health advocate.
Thanks, Dan.
And you have a great echo, Dan.
Yeah, it actually sounded really cool, but you do have an echo.
I can go. I'm Bert. I work in peer support and have for many years now. I'm also on the board of directors for Vermont Psychiatric Survivors. I'm glad to be a member of the committee. And I'm encouraged to see that we'll be doing quality control again today. So, or quality assessment anyway. Excuse me.
My name's Greg. I do peer support down here in South County in Bennington, and also advocacy, and I also do run a peer mental health education group at our CRT down here through a POP grant. So, and I hope to be on the committee and get my paperwork in, and my pronouns are he, him.
And I'm Beatrice Birch, and I'm a guest that would be interested in being on the committee as well. And I'm the executive director, founder of Inner Fire near Brattleboro, Vermont, and we offer people the choice to have the support to come off their psychotropic medications while strengthening themselves on a deeper soul spiritual level. So this was catalyzed by a number of young people who came to me hating being medicated and seeking a choice, and who didn't find it and ended up taking their lives. So it's in honor of them that Inner Fire was founded.
This is Vicki Warfield, she, her, member of the committee.
And I'm Sharon Levinson.
Her member of the committee.
What's that?
My name is Erin Nichols. I she, they pronouns, and I'm a peer support advocate at HCRS in Hartford, Vermont.
This is Tom Johnston. I'm representing Vermont Psychiatric Survivors as a guest. Thanks.
This is Sharon Levinson. Can you hear me?
Mm-hmm.
Oh, yeah. I live in Guilford, Vermont. I'm a psychiatric nurse. I run a wellness program at Clinical and Support Options, and I also have my own wellness program that I'm starting via telehealth, Levinson Health and Wellness. And I've been a psychiatric nurse, and I am a guest hoping to become a member of the committee. Thank you for having me.
Great.
Welcome.
Thank you.
And it sounds like I may be the last one. Eva Dayan. I am Quality Management Coordinator at the Department of Mental Health. I use they, them pronouns, and I will be here to support the committee today.
And there is one more. I'm Lynn Cardozo, and I am considering applying to the committee as well. I've attended a number of meetings, and I'm the director for the Vermont Communications Support Project, along with someone with lived experience. And I'm here by phone because I'm afraid I wasn't able to get on to the Skype. More people on the mountain using up the bandwidth these days.
I think a lot of us are on the phone.
Yeah, that is true. There's mostly people on the phone. Is there anyone else who hasn't introduced themselves who'd like to? Okay, great. Well, thanks everyone for being here. We usually try to begin by committee members just checking in about how do we want to relate to public comment today? Do we want to sort of have that be contained within the 15-minute designated time at 2:45, or do we want to allow public participation throughout the meeting? Do any committee members have opinions about this today?
I do, Malika. Well, first of all, number one, we've got background noise there. Number one, we've got a very full agenda. Number two, by my count, I think we have at least 5 guests. So unlike what I normally prefer, which is an open meeting with open to questions, I think we're in a position where we do need to put in place some restrictions, and my recommendation is to allow questions during the DMH update, since the person will be here for that time, and then ask the guests to refrain till the end, public comment, for anything else that can be answered by the people who are at the meeting for the whole time.
Dan, this is Ward. Do you want to consider letting or recommending folks to type in the text box if they have questions? I mean, just to get a running tally of them.
Actually, that's a great idea. Unfortunately, I think most people are by phone.
Oh, so that's right.
So,
well, if those people would just log in, then they could do that. Anyone who does, I guess, can certainly have access to that. Can certainly do that, I think.
I support Dan's proposal.
I as well, Thelma. I was thinking mostly no, but I think it makes more sense to allow for some public comment, just not through the whole meeting. So,
yeah,
I agree.
This is Ward.
Yeah, I mean, I would. I think I both feel like DMH update is a very, very one of the most sort of like places where we don't have enough time, and also there may be situations where members of the public have relevant information to share about something that we're discussing, or opinions, and I wouldn't want them not to be able to share those then. So I wonder if we can sort of have members of the public indicate that they have something to share if or when that comes up, and we can, regardless of what section it is, make time if there is time. Is that too complicated? I'm also happy to support your suggestion, Ian, if that feels better. And can people please keep themselves on mute when they're not speaking? Thanks.
I'm forgetting offhand, Malika. It's *6 if you're using a telephone, right?
I know that's what it is on Zoom. I'm actually not sure on Skype.
Okay.
But I think you can also just mute your phone in most cases.
So, Malika, just to be clear, you're proposing that we waive the restriction on public comment for the meeting, but just ask members of the public to just, ask if they have a comment so we can check to make sure we have time for it?
Yeah, it's like sort of like a partial waiving of the...
Yeah.
Yeah.
I'd go with that. That seems good.
What do you think, Dan? You're mute.
Yeah, I'm okay with that. I would just ask the public if it's not something they feel is timely, to hold it till the end. So I guess we'll just we'll see if we can make it work and just leave everyone up to their own best judgment.
That sounds fine to me, this ward. Yeah.
This is Thelma. That sounds fine to me.
Do we need a motion and a vote, Malika? Hello?
You're muted, Malika.
Yes, I guess I think we do.
Okay.
So I move that we allow public comment, but first ask the public should ask if there's time, and ask them to hold questions to the end if they think
They can.
if they're not timely and need to be addressed right on the spot. Whatever.
I second that motion.
Great.
Aye.
Thelma seconded. All in favor?
Aye.
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 Any opposed? No, great. So moved. We have 2 sets of minutes to review and vote on. The first is from June. These were sent out at least via email. And it looks like the changes, because we talked about these minutes previously and had recommended some changes, and it looks like those changes are highlighted in yellow. Should I just talk through those really quick?
That would be much appreciated.
Okay. Looks like it was noted that Lynn was present as a member of the public. There's a note that we requested that the update did not happen at the scheduled time on the agenda, and the confusion about which member of DMH leadership would attend caused disruption in the meeting flow. So that was added. And that section was labeled as impromptu DMH update. And then per our request, there's a new section broken out separately from the DMH update that's called SPSC member recommendations. And these recommendations that were added were that we stated their preference that funding go into prevention and community resources instead of any new inpatient or secure residential beds. And we encouraged a continued focus on testing for COVID-19 in inpatient units. And then there was, in addition to the public comment, there's a question for Dr. Is it Weigel or Weigel?
Weigel.
Weigel. Okay. Dr. Weigel, what accommodations for physical distancing are being offered to people with mental and physical disabilities within and beyond congregate settings? Are there any comments, concerns, clarifications about the June minutes?
My signal was in and out, Malika, but I trust your judgment. So when we get to the listening tour draft, I noticed a typo potentially. It's a different issue, but anyway.
I'm good. I'm good with them.
Great. Okay. Any other comments, or someone want a motion to approve?
This is Ward. I'll move to approve.
Okay.
Seconded.
Great, thanks, Dan. And all in favor, if there's no discussion?
Aye.
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 Great, any opposed?
Aye.
Okay. Moving on to July minutes. Has anyone
You're breaking up.
have any questions? But I'm sure that is just me.
Yeah, I don't think we
I
can
can't
hear you
hear.
right now.
Say a few words, Malika.
Can you hear me okay?
I can hear you, but your video's frozen.
Malika, were you asking for comments about the July minutes?
Yeah, Dan, I think this is Ward. I think that's where we're at.
Okay.
You have comments?
I have comments. First of all, very, very well done. These are great. One suggestion though is just to add page numbers on the minutes, and that's a general suggestion for every document that we get. It just makes it easier for referencing. For example, on what is, I think, page 4, under a little bit above the middle, the bullet, under the bullet, racial justice and inequity. Here we have an editorial comment. I know we've run into this in the past, where the minute taker added parenthetical note about looking for some information that apparently was supposed to be available at the website. I'm not sure that editorial comments should be included in our minutes, but on the other hand, it's a spot-on comment, so I'm not exactly sure. I have a strong suggestions about how to handle that. Maybe put an asterisk and put it at a footnote at the end might be a little more in line with meeting minutes, but I'm curious what other people think, because we have run into this before, where either the minute taker or DMH has provided editorial comment.
Dan, I apologize for that. My intent was that the parenthetical comments would not be in the final minutes. They were just kind of added to draw members' attention so that we could maybe address the question as we're going through the minutes. But my intent was to take this out before the final draft is published.
Okay.
And if there's a better way that I should be doing that, I definitely want to. I just wasn't sure where in the agenda we would be able to address those issues otherwise.
Maybe that's a great. I'm glad you clarified, and no need to apologize, Vicki, at all. Maybe just put it in brackets rather than parentheses, and just put draft note or something that would indicate like this is a note to be discussed but not part of the minutes. I mean, that's my suggestion, but yeah, I'd hate to take it out totally, because it is something worthy of discussion.
Yeah, that's noted. I'll make sure of that going forward. Thank you. And the page numbers, I'll make sure to add page numbers to documents.
Yeah. Minor, very minor, Vicki. Great minutes.
I've switched to phone audio. Can y'all hear me okay now?
Yes.
Yes.
Awesome. Great. Are there other comments about the minutes? I want to say thanks so much, Vicki, for this. Yeah, work. It's a lot of work. And I think it's great. Thank you.
Absolutely.
Thank you.
I motion to approve the July 13th minutes.
Thank you.
This is Ward. I'll second it.
Thank you, Ward. All in favor?
Aye.
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 Any opposed?
Aye.
Any opposed? Okay,
And I'll
great.
make those two corrections and send Eva the update today.
Great.
Thanks, Vicki.
Thanks,
Should have
Vicki.
said approved with the, with the corrections that we talked about, but. Awesome. Okay, so we're at 12:27. And the things that are next on our agenda for this chunk of time are talking about the listening session and next steps there, the secure residential facility, aggregate grievance and appeal data, and history of the committee's main tasks, current main tasks, reimbursement for member time outside of meeting, and membership update and discussion. Which is a lot of things. Do we have another point in the agenda today for these things? No, we don't. So I think that means we need. Sorry, go ahead.
Malika, I'm sorry. I know we have a really crowded agenda, but last month we talked about I would set up a shared folder and report back to the committee, and I can do that in like a couple minutes, but I thought that should be mentioned.
Yeah, I mean, we're sort of doing admin-y things right now anyway, so that sounds good.
Yeah. Okay.
Do you want to tell us about that right now?
Oh, yeah, sure. So I don't know if I made this overly complicated. I set up a Google group for us, and actually just set up Google Suites as like I set us up as an organization, the Department of Mental Health Adult State Program Standing Committee. So the way I set it up, I'm new to this, so there's going to be some hiccups, but the way I set it up, everybody should have received an invitation or a notice to their email address that should link to our shared folder. You can put any documents in that folder, and any documents that you put in that folder, all committee members will see. From now on, if you email the address members@dmhaspsc.org, it will go to everybody. So instead of having to type everyone's email individually, that should go to everyone. And the shared drive has a working document of all open action items, and then also recommendations that we've, action items and then recommendations that the committee has made. Then it's also got a folder for minutes, transcripts, and it will have a folder for agendas. So it's everything that's published on the DMH website, plus the things that we're currently working on and the recommendations that we've made. And then finally, just sort of a byproduct of going through this process, everybody got their own email address. So if anyone wants to use that, you certainly can. It's optional. But everyone has their first name at dmhaspsc.org. And if you want to use that, just email me, and I can make sure that you know how to access that. So that's pretty much it.
Vicki?
Yeah, this is Vicki. So if we like this, we can certainly keep it. If we don't have to keep it. This is more like a trial thing. And if anyone doesn't want to use it, you won't miss any information. This is all stuff that we'll be sharing by email. It's just one spot where if you want to only see emails that are just, for me, like, things were kind of getting lost in my inbox. So if I want to see just emails having to do with the committee, they'll be in one spot. And if I want to see all the documents, and if anyone edits a document, their edits will be updated for all committee members real time. So that's kind of the purpose of it. But it's nobody will be missing anything if they don't use it. So that's all I had to say, unless anyone has questions.
Thanks, Vicki.
Sounds good.
Yeah, incredible. I think it's a game changer. I think it's going to help us do our work, more efficiently and in a more organized way, and therefore do more, which desperately needs to be done. So thank you for that.
Vicki, this is Greg, the guest.
That's great.
Is that something that would be available for guests, or do you have to wait till you become a member for that?
Right now, this is just kind of a test run for guests
Okay.
or for committee members. It's just kind of like our internal working documents, so that we have a place to collaborate on things before we have like a published public version.
Okay, I'll just keep my patience then.
Thank you.
Thank you.
And maybe we'll just give everybody, I would propose we just give everybody a chance to kind of check it out, and maybe we can vote next month on if we want to keep it.
Yeah, that's great.
Cool.
Yeah, or let it run for a couple meetings or three.
Yeah,
just
okay.
give us all time to kind of play with it and de-kink it, unkinky it.
I'm sure there'll be little things to pop up. I'm sure. Just email me if there's any problems, and I'll figure it out. YouTube has been a big help with this. So, all right.
Cool. Thank you. Awesome. Cool. So, committee members, what of these other items is important to prioritize today? I know that a number of these have been pushed over.
I have
updates about the listening tour. Sorry, go ahead, Dan.
Oh, sorry, I didn't mean to interrupt.
Go for it.
Unless someone has another suggestion, I'd like to throw out that the all but one of the membership related, the committee history and then the membership related, be put on the agenda next time. And I'd also like to suggest, because there are a number of issues relating to membership going on right now, including we have an overwhelming number of guests and potential members. But I'd like to suggest the membership committee meet between now and the next meeting online and sort of get organized around membership. I've been doing some reaching out to do exit interviewing and so forth and so on. But I'd like to put that on the next agenda and make sure we carve out enough time for it. The one thing I would ask, the one item I think we could probably address right now is the reimbursement for member time outside of meeting. I think that's a DMH issue.
So you're suggesting, Dan, we focus on the listening session and the secure residential
and grievance.
Can I just confuse the issue a little bit? We have a lot of potential new members. One of the things I brought up was, can we get them on is it okay for them to be on our mailing list so they can see the conversations that we're having, so that they're included even if they're not members? So I don't know if Eva can collect all the emails and then we can add them as a CC or something like that.
I do have a list of potential member emails. Who's on that list can change month to month. So if I just get some guidance from the committee about if you wanted like an updated list of emails every month, I could do that. But just how you wanted to manage that would be helpful.
If everyone on the membership subcommittee would be in favor, I think that would be one of the things that'd be really useful to have on our shared drive so that we can all access and keep it up to date.
Yeah.
I agree with Vicki in that I feel like most of our email communication is professional and appropriate, but it's maybe something to work towards. In that I think we should utilize the Google Drive and allow opportunity for public comment as well moving forward, but to also maybe think about word suggestion as being maybe more than what's necessary for public transparency.
Well,
I mean, I don't know what your objective is in mind, Ward, but
yeah,
I think
I'm
that,
more, maybe it's appropriate for what Eva sends out and not necessarily what we send back, but yeah, I want the new members to have visibility into what is going on so that they understand what we're doing and are prepared when they come to the meetings and fill out their paperwork to become members soon.
Yeah, maybe the membership subcommittee, if they convene during this next month before our next meeting, can come up with a recommendation and bring it back to the next meeting.
Okay.
Okay, we can do that.
Great, and I would encourage any members of the public to email any of us or Eva, or speak up in public comment about if you have an opinion about what would be helpful and work best here. I don't think we should get into a conversation of figuring that all out right now because we have, 20 minutes to resolve a number of things.
Okay, sorry.
Dan, did you have a thought?
No, I just wanted to confirm that the membership committee, I think it's Marla, Vicky, and myself. Is that true, Eva?
That's true. It sounds like Marla may be taking a leave of absence, so right now it sounds like you and Vicky.
All right, so I guess I'd like to throw it out. Does anyone else, anybody else on the committee like to join us?
I'd help with it, Dan.
Great,
I'd
thanks,
be
Emma.
interested. Oh.
Was that Kate?
I've helped, but maybe a more experienced, but I'd also be interested in helping out if that would be appropriate.
Oh, totally appropriate. The membership should consist of people with a range of tenures. Makes complete sense to me anyway.
Yeah.
I personally am trying to keep my workload for the committee manageable, so it's definitely an interest to be more involved. Maybe not quite timed as of yet, Dan. But
so
I agree with you, Dan. I think the history of committees can maybe be held off if we have more important work, especially considering that we have a CSAC redesignation to think about. And I feel like the membership discussion can be had outside of this time.
So we'll add Kate and Thelma to the membership committee. Thank you, everybody.
That's great. Thanks. I also want to suggest that we hold off on the conversation about the secure residential for the moment because it's a really big conversation and yeah, that's it. Well, I guess I would suggest we talk now about listening session next steps and an update about that. I don't know if Dan or Ward, if you'd be willing to give an update.
Ward? Sure. Yeah, this is Ward. So yeah, I think everyone's had a chance to maybe look at the project plan. I call it, it's kind of fancy term. But I tried to create that document so that everyone have a good idea of what we're trying to do in the listening tour and what our plans are. And towards the end of that document, there's a list of the actions that we're working towards and the status of those actions. So I think things are moving along pretty well with the listening tour at this point. But, we're up to the real important part, which is coordinating with the hospitals and getting a time and all the details of just how it will work. There's the basic plan for the listening tour is it's going to be, virtual, be led by either Dan or Malika. Let's say maybe one note taker to help, or one or more. There's going to be some things for us to talk about, but we're torn between having too many people from the committee on the participating only from we don't want to crowd people and make them, feel uncomfortable. One of the goals, simple goals of this listening tour is that the people that we're listening to and talking to, kind of get a good feeling from the event. I mean, that this is a good thing. It's something that they enjoy and that they're hopefully, would want to have it happen again if they could. That's my ideal, at least. I don't know, Dan, if you have anything to add in terms of where we're at with the hospitals, that might be helpful.
Yeah, well, first I'd like to just reinforce what Ward was saying. Malika and I, Ward, talked about this issue of committee members or other people participating, and I personally feel that we need to keep the number low, just because we want to do everything possible to make the environment. Someone should probably be muting now, but we want to do everything possible to make the environment conducive for people talking openly, and the more non-patients that are on the line, then the more. Yeah, I think that it may. It's possible it could stifle the openness. But in terms of where we are in the timeline, I have reached out to each of my contacts at Central Vermont Medical Center and Vermont Psychiatric Care Hospital. Those are the two inpatient psychiatric facilities or units we're starting with. I've talked to my contact at Vermont Psychiatric Care Hospital, and he didn't see any deal breakers per se, but he did need to run it by a number of people and is going to get back to me in fairly short order. I told him we really want to get this done and try to get it done as early in August as we can. And haven't heard back from CVMC, so I will reach out to them with a follow-up. Oh, and the other thing is we've created a draft agenda and list of questions, and Malika and I are working on refining those. And then I think I'd like to get those out to the whole committee to look at that once we've got a full draft ready.
So, yeah, and relative to that project plan, I mean, if you have any comments or I think Bert, you had a comment, you can just send that to me. This is Ward, and I can address things that you want to add in or change.
I have a question. This is Vicky. Is this an okay time to ask it, or given how full the agenda is, should I just email?
Go for it.
Okay. So the listening tour, I'm sorry, I'm kind of coming in late, but the listening tour is to get the perspectives of patients, correct?
Yes. Yep.
How are they selected?
How are they selected?
Yeah.
Everyone in the on the unit or in the hospital that we're touring, quote unquote, is invited.
Okay, I was just thinking, since when I was patient rep, sometimes there were a lot of issues around access to communication within the inpatient units, and I was just wondering if it might be a more inclusive and representative and fair process if the hospitals would be willing to give an invitation also, like in addition, give an invitation to people on discharge, so that they can call in, and they've been recently on unit. Like within just the past, just between now and the time the listening session starts, and that kind of provides access for more patients and more representative sample possibly.
This is Dan again. Actually, I'm glad you brought that up, because originally we had talked about listening tour including discharged patients, staff, family members, but I think at this point we're kind of trying to be more and more focused and just try to get done the core objective, which is patients. But I do like the idea, if the hospitals are willing to invite anyone who's been discharged since the beginning of the,
Well, I don't think they would reach out retroactively. At least I know the retreat would not do that. But I just know that I was very limited in which patients I was able to access when I was actually going in. So I would worry we might not get a representative sample if we're leaving it up to the hospital to provide access to specific patients while they're inpatient. But that's just that was my only thought, so I thought I'd bring it up.
I think it'll be a difficult thing to guarantee, and we won't be able to for sure. I think we can consider doing some other ways of gathering information as well. And I think there's some like challenges and capacity challenges around that. But I think, yeah, if anyone has like an idea of how to make that work, such as like a survey that goes out to people or something like that, or being a person that folks can call and share their stories with, I think that'd be awesome. And we'd need, someone with the capacity to like sort of make that happen. Also, just FYI, I know that a member of the public will be joining a little later and sharing during public comment about their recent experience with the emergency department and hospitalization, to help us have a, sort of more of an insider perspective about that.
Great,
yeah.
Thank you.
We actually, good point, Mike. We had actually talked about possibly doing a survey for the other constituents. So I'd like to suggest that we'll take that one back and consider how we might be able to logistically get feedback from recently ex-patients.
Awesome. Yeah, and big shout out to Ward and Dan for the work that they're doing to make this happen. And it's moving forward, and it's really exciting. And hopefully we'll be a pressure that we can sort of keep up.
Yeah.
And shout out to Malika as well for all your hard work.
Thanks. I'm not doing that much, but so the grievance and appeal, is it okay to move on? Anyone opposed to me moving on?
No. Okay. Move on.
So grievance and appeals stuff, we only have 10 minutes. I don't think we can really get into this. My sort of initial reaction is, well, one, I've never seen this kind of information come to the standing committee before, so glad that it is happening now. And it's really hard to know what to do with this amount of information. I don't know if anyone else had that reaction, but like I'm wondering if it's possible for us to have, more of the details about any of these things. Does anyone else have any other comments or reactions?
I do.
It was. Oops. Go ahead.
No. Everybody else go first. I've been talking too much.
When I was reading it, one of the things that I wondered about, and I know that this is just a foreign to let us know the information, is I was wondering how things were resolved. They just said yes instead of saying, what came out of it or something like that. That might have been a little more helpful.
Yeah, that's exactly what I was thinking, Thelma.
This is Eva. This is the level of information that I have access to. So that's as much as I have the ability to show. I can bring it back to DMH and ask if it's possible to have more information, if this is something that you want to explore further. If you could just tell me like what concretely you're hoping to get, I can see if that's possible. But this may be a limitation of our system. It may be that all we see as a result of these are the yeses or nos in terms of resolved.
Right.
Given that they're worked through on an individual basis at the agency level, at the designated agency or specialized service agency level, and we really see just like this broad level report that comes in that says here's the type of grievance and it's followed the process given the right steps in the right time frames, and then it either got resolved or not, I think is what we see.
Yeah.
This was great, by the way, getting this, Eva. I haven't seen anything like I said, we haven't seen anything like this before.
Yeah.
So thank you.
And Eva, this is Ward, and the comment about how did these things get resolved and some amount of information on that. Both this committee and the Children's Standing Committee have the same issue with the report that was provided on that. So it's an important piece that hopefully the group can go back and come up with that, because it's really important for people to know how things got resolved.
Yeah, and I don't know, it would be great to see everything, but maybe it's an issue of sampling, of providing some of the information about the resolutions. I have a question, Eva. I know that this particular reporting is about aggregate information, but is there a reason we can't get information about where these particular grievances have occurred?
Yeah, so I can tell you it's from a variety of DAs across the system. There wasn't one DA that seemed to be more represented or less represented in this particular sampling. But because things were resolved or are addressed, hopefully, at the local agency level and then are reviewed at that local level. So if Washington County had a grievance, then the Washington County Local Program Standing Committee would be reviewing that in more detail. And so the thought was to keep things broad level across the state. We would give the view that these are what the statewide issues are. Because otherwise we were worried we would be kind of directing you towards trying to give specific feedback for Washington County, when really that's the job of the Local Program Standing Committee, is to see their trends specific to one agency.
Yeah, I guess my concern is number one, if there's a disproportionate cluster at one or more of the DAs, or on the other hand, if there are little to none coming out of certain DAs, then that also gives me concern, which leads me to another issue, Eva, that perhaps we could address at another time, which is, what are the checks and balances in place to assure that all grievances and appeals are reported? I don't want an answer now, but that's just something that it's always on my mind when it comes to reporting negative information like this. The other thing, Eva, just for future, you may not be able to go back and get previous year's data, but at least if going forward, we could capture and report information over time. So a year from now, we'd have 2 years worth of information as an example.
And Eva, this is Ward. I mean, on the children's side, there were only two at the first report provided to the committee. There were only 2 grievances or appeals listed. With a little further investigation, it was found out that there were other grievances that had occurred but weren't in that report. Do you know if this report has the same problem that the children's report had?
So this has all of the grievances and appeals that have been reported through the grievance and appeal warehouse. So we require agencies to submit all grievances and appeals to our warehouse. We've noticed in the last year, like when we shared data last year about grievances and appeals, it was just that list of like numbers. And it may have even said by agency, but it would say like for Washington County, 2 appeals or whatever. And we noticed at that point, wow, they're low across the system. So the last year, we've given a lot of feedback to agencies. We developed or your group developed a flyer about grievances and appeals to share with agencies. And we've given feedback during designation times to say, on a lot of the designation reports that we've reviewed recently, we've seen that that's a finding from DMH that agencies need to be reporting more consistently and using the warehouse more consistently. So yes, this report includes everything that DMH is aware of in the last year for adults.
Thank
Okay,
you.
so
Vicky,
that's good.
This is Vicky. Eva, do you know if this includes inpatient facilities?
No, this is only at designated or specialized services agencies that serve adults.
I would suggest, as has been mentioned by committee members, I'd like to look into kind of the checks and balances system. Maybe the committee could spend a little more time doing a more thorough review of the grievance process. I noticed some issues with like inpatient grievance process when as a patient rep, my job was to go in and help people through the grievance process. And I had some concerns when the flyer came out that people were reporting issues with their case managers who had, influence over their housing and their access to their finances and, had a lot of control over their lives. They didn't have any way of reporting a grievance with any confidentiality or any assurance. There's no policy against retaliation. I just kind of like I think this is an important line of communication for us to the quality of care being provided to Vermonters. So given the significance of the issue, I just suggest that the committee, whether we form a subcommittee or just want to spend more time in another meeting, but come up with a list of questions and maybe have someone from DMH come and do like a Q&A session and we could sort of give this a deeper look.
I like that idea.
Okay.
Maybe
I do too.
Next meeting, I think we're going to be meeting with CSAC, so maybe the following month, put it on the agenda, and then between now and then we can send questions and they can be consolidated, and someone who could from DMH could be prepared to talk about all of these issues.
Great. October. Yep, I can add that to the October agenda.
Awesome.
Yeah,
Thank
because
you.
there's nothing on the October agenda as far as the items planned for next time.
Yep.
Yeah,
Good point,
thanks
Thelma.
so much. And Eva, these are, can you just clarify, are these grievances and appeals made to the designated agencies or are they ones made to DMH? Because my understanding has been that those are both possibilities that are separate.
They are made to the agency itself and then reported to DMH. If DMH has a grievance that's made to us, we try to assist folks in going through the grievance process at their agency.
Okay, interesting. Yeah, sounds like we should learn more about this whole system. So the recommendations are we look at info over multiple years. We have info broken down by DAs. We have more details, including what that resolution actually was. That we also have data about hospitals, and that we have a Q&A and a general review of the grievance process and the checks and balances in it.
And the confidentiality piece that Vicki talked about too.
Yeah, I mean, one sort of middle ground regarding the reporting by DA. I can understand not knowing where each individual grievance came from, but if there was a table at the end which said total number of grievance 42, and just for the whole reporting period just says just numbers for DA, that to me would be enough to give me a sense of what's going on and what's not going on at the DAs from a higher level. So we can add that to the list of things to talk about in October.
Got it.
It's 1 o'clock. Who is doing the DMH update today?
The plan was to have Fox here with Dr. Tom if Fox is unavailable.
Fox is unavailable?
The plan is to have Fox, but in the event he's not available last minute, then Dr. Tom would come on.
Okay.
I believe they're just getting out of a leadership meeting now, so they should be here.
Well, while we're waiting for them, hopefully they'll be here in just a minute. I'll just let the committee know that I think it was in an email to all of us that our questions about the secure residential and particularly the data that we requested, we meaning people at the stakeholder meeting, not this committee, requested. But then I think this committee then followed up with asking for that data. That, I guess, was considered a public records request. I'm not sure sort of why or where that came from, but I was emailed today individually, I don't know if you all got an email as well, some of the relevant data, not all of the relevant data that was requested. So I'm not sure what happened there, but I've asked Eva to forward that information along to everyone else if y'all didn't already get it.
Yep, should be in your
but
emails.
It's certainly not the complete data that we asked for. Was that Eva?
Should be in your emails, yeah.
Okay, great.
I received it.
And that's
I'm sorry, are you referring to the racial equality data or the water quality management data?
Neither. It's actually data about Middlesex Therapeutic Community residents and how often people sort of return to the hospital from Middlesex. That data is there, but what we don't have is data from other residential programs as a point of comparison about how often people sort of went back to inpatient from Middlesex.
okay. So that's the part I think we needed just a little bit more clarity around is finding comparable residentials to Middlesex. There aren't comparable residentials in the state. It's the only level of care like that in the state. So if you'd like to see other residentials, then I'll let them know that, and hopefully we can get you that.
Yeah, what I wrote was comparable data from other residentials. So the same data points from the other residential programs. Not that they're necessarily comparable, but
Hi, this is Fox. I'm on.
Oh, great, thanks.
And this is Tom. I'm on too.
Hi, folks.
Awesome. Thank you for joining us.
Yeah.
And Trish, I'm on as well.
Was that Sarah?
Trish is here as well.
Trish.
Oh, Trish. Okay, great.
Dr. Trish.
Great. Great.
And for folks that are just joining, we are recording the meeting.
Yep, thank you.
I think we are ready to hear the update, and saw that there's topics outlined in the agenda. I'm assuming you all have that as well, but if you want me to list those, I'm happy to do that.
If you could just give me like the first one, Malika, I just don't have it in front of me. I'm trying to, having some computer problems. That's why it took me a little bit long. So I finally just logged in through the phone number.
Yeah, no worries. That was most of us earlier anyway. Yeah, so the first thing is follow-up from July requests, and that included the secure residential data. We were actually just beginning to discuss that. Inpatient technology access, inpatient representative coverage, and racial equity data, which was emailed to us actually. That's the first topic.
All right. So as far as the data goes, hoping that everyone's received that data on the discharges from Middlesex for folks who return to higher level of care, in other words, a hospital. and such. And I was advised to make sure that it went through our public records request process, just to make sure that if anyone other than myself had other data, to make sure we had all the appropriate data that we could supply to you guys, and such like that. And it just helps us to make sure we're organized and making sure that all the data we do have gets to you all. And so I apologize if that slowed down the process a bit, but I wanted to make sure that it was, just in case I wasn't holding on to the most recent or accurate data, that our research and stats folks were involved and things of that sort. So hopefully you received that data already, and please let me know if you have not.
Yes, we did. Thank you for that. And we were just clarifying with Eva that there was sort of another piece that we were looking for, which is comparable data from other residential programs. So both how often do people still start to go back to the hospital, but how does that compare to the other residential programs?
So could you just, thank you for that clarification. I think the way, we read it on our end was other comparable data to other facilities like Middlesex, and we don't have another facility like Middlesex, but so what you're saying is that you're looking at more other residential facilities and kind of what happens with them as far as how often or what the data shows as far as people going from residentials to hospital level of care or higher levels of care. Is that what I'm understanding?
Yeah, exactly.
Okay. So what I would ask is, could you write that out into either a Word document or just even an email, just so we have it clearly written, and then we'll make sure, again, similar through our process, we'll include everyone in our department to make sure that we're covering all the data for that. And be specific. Let us know, are you talking about intensive residentials? Are you talking about level 3 community care homes, group homes, those types of places, other TCRs in the state? Just want to make sure we're getting you the data that you're looking for.
Yeah, I can re-forward the email that has that language.
Great. Thank you, Malika. I appreciate it.
This is Vicky. I just wanted to make a note that I received this information, but I received it about 45 minutes into the meeting. And this has kind of happened before. I just like to request that if there are materials that we have a chance to ask DMH or provide feedback on, that we get them at least 24 hours before we're supposed to respond to them.
Yep. If you get me that request in the next couple of days, we'll turn it around in a couple of days.
And I was wondering, could you just clarify what the specific demographic, what the requirements are for someone to be referred to the Middlesex facility? What specific demographic you serve there?
Basically, the idea behind a referral to MTCR versus another intensive residential, the main factor there is that they require that extra level of security. That they require the need for locked doors or a fence where they cannot walk into the community, things of that sort, unattended or without staff.
Right. Is there a standard process by which that's evaluated?
The standard referral process when people are referred from hospitals?
No, not a referral process. A standard process to assess who needs to be in a locked facility, level of that. A standard way of evaluating who needs that level of care.
I think it's more a discussion of the clinical presentation at the time of any individual.
Okay.
Based off of those clinical needs.
And can I verify that this new facility that's being built serves the same demographic as the Middlesex facility, and that this is setting the precedent as the first time use of physical restraint would be part of a residential facility in Vermont?
Yes, it would be the first time for any residential, for a mental health residential an adult mental health residential facility to have that capacity.
And the criteria for admission would be the same as Middlesex? They'd be serving the same demographic?
Generally, although you may end up adding into that conversation if someone also has intermittent or episodic outbursts that may require an emergency involuntary procedure, that they may be considered for that facility instead of just the need for a locked facility.
Has DMH done any kind of comparative research to see how other states or even other countries are handling that same demographic, whether other areas are resorting to use of restraint, or if they found ways of managing the same population without that level of restraint?
We've not looked at other countries, and we're not aware of other facilities like this in the United States at this time. What we can tell is that folks who have that similar presentation remain hospitalized in other states.
So they wouldn't even go to a facility like Middlesex? Like Middlesex isn't something that
Correct.
exists elsewhere in the United States?
Correct. They would remain
There's also
hospitalized.
Fox, maybe you can correct me if I'm wrong, but I think a lot of states have state-funded forensic facilities where people would be if they were both mentally ill and unsafe from kind of a mental health / criminal perspective. So there's people who may be in another state in a forensic, kind of a dedicated forensic facility. And so I don't know if some of those people may end up at Middlesex or may end up on inpatient units, but I think that's some of what the state of Vermont deals with in not having such a facility.
Nope, that's correct.
So Vermont doesn't have a forensic psych facility?
We have no facility for anything forensic other than correction.
What happens to people if they're experiencing an extreme state, if they're in the corrections system?
If they need hospital level of care, they can either be voluntarily admitted to a hospital or they can go through the EE process and be civilly hospitalized on an involuntary basis. And that's generally at either VPCH, occasionally at maybe the Retreat or Rutland, but they're very reluctant, honestly, to accept forensic cases because of the complex nature and discharge planning issues related to that population. And so the other level 1 hospitals are not a regular or routine referral source for folks because of that.
So in general, corrections is kind of providing its own mental health services to people.
I'm sorry, I couldn't hear that.
So in general, the Department of Corrections then would necessarily need to provide its own mental health services to people regardless of their acuity?
Except if they need hospital level of care, then they would be either voluntarily or involuntarily hospitalized.
But that could be up to the hospital to accept.
Well, if the other hospitals don't accept, then that's when they, by default, will end up at VPCH. We will not deny someone a hospitalization if that's what they require.
Understood. Thank you.
And
I think it's similar to the medical process. If somebody needs medical services, that's provided through the Department of Corrections. But if somebody's having a heart attack or a stroke, they'll end up in the ER or on an inpatient medical unit.
Right. And the Department of Corrections contracts with a health provider that provides both physical and mental health services. They have a new provider that started July 1st that they're working with at this point. So they have a new contract with a new provider been the one that's been providing the health and mental health services over the past 3 years in corrections. But they provide statutorily, both within Vermont and federally, Department of Corrections is statutorily required to provide the health and mental health services up to, but short of need for hospitalization services.
I'm wondering if there's data about that we could look at maybe over the last couple of years that tells us how many people in any of the Vermont hospitals, and particularly in VPCH, I can write this down because it's going to be easier, are considered forensic patients. I'm interested in knowing, like, sort of what volume of people we're talking about, what percentage of people at VPCH are in that category.
Sure. Yeah, no, that's a fair thing, and we do have that data, Malika. So yeah, include that in what you're writing up already in the data, and we can pull that.
Okay, great.
Is there any oversight, since I believe many inmates are sent out of state, if Vermonters in corrections out of state, if their mental health needs are being met, if they're being hospitalized, if the numbers are similar for the services they're receiving as Vermonters being incarcerated in state? Is there any kind of data that we have or oversight on whether these two populations are being treated equitably?
No, not from our end. That would be a conversation you would have to have with Department of Corrections. We don't oversee the mental health services that are provided within the Department of Corrections.
And we don't oversee what's done in Mississippi either.
Right.
We should probably move on to inpatient technology access and inpatient representative coverage.
So I'll let Tom speak to some of the technology pieces.
Malika,
as far as the rep pieces. I just want folks to be aware that I did have a conversation along with Trish, I believe it was last week, although it could have been 2 weeks ago, or my mind's a jumble. It just yesterday seems like 2 weeks ago to me. But I think it was last week we had a conversation with the leadership at Vermont Psychiatric Survivors. And they're in the midst of hiring process, both for their executive director as well as to replace the two recently departed patient representatives. And it's my understanding from that conversation that they have a number of good candidates, both in the Burlington area as well as in the Brattleboro area, and that they're going to be starting that interview process shortly.
Do you have any data on whether...
Go ahead.
Has DMH verified whether any patient representation has been provided since the pandemic started in early March? So it's my understanding that the patient reps were not working since that time.
I don't have in front of me that answer, Vicki, but it's my understanding that accommodations have been made at all hospitals to allow for the patient representatives to connect with individuals on the units via phone, Skype, whatever kind of means necessary. My understanding that at least up until recently, if not still currently, visitors have been denied access of all ancillary services. Similarly, at VPCH, social work and other folks are working remotely, all in an effort to maintain the health of those units and mitigate and minimize the potential risk of exposure by bringing any individual in from the outside.
I believe last month we clarified that we were asking specifically how many patient reps were working at which inpatient facilities, how available they are to patients, and how patients are being made aware both of their patient rights and how to contact info for advocacy groups, which I believe is outlined in statute. Do you have that information available this month?
I would have to see. I would have to check and see what data we do have or not. That's not something that normally crosses my desk on a regular basis, so I'd have to see what data we have.
Given that we've made
Hi,
that
this is
specific
Tom Johnston. I'm from VPS. I could probably address some of those questions if I might.
Yeah, could you just hold 1 second for Vicky to finish that thought, and then
Sure.
Yeah.
Oh, I was just asking, since it seems like we've asked these questions and then we've clarified them, and then we specifically clarified them at the last meeting, if there's a different process we should go through to request this kind of information.
I guess I would respond similarly to Malika and just include it in a written request for data is the best way to make sure that we actually capture the request and make sure we get you the data that we do have.
Is including it in the action items in the minutes that I submit to Eva enough of a written request, or does it need to be an email address specifically to you or Sarah? Just not sure. How do we submit that?
The preference would be a separate email, whether it's sent to Jess Bernard or to Trish or to myself. That doesn't matter. But having it embedded in the minutes isn't something that's necessarily going to trigger that, and it may not be read in a timely fashion either.
Understood. From now on, if the committee makes a request, we will make it in writing in addition to and anything we say in meetings we'll also make sure is in writing and sent in separate emails following the meeting.
Just to clarify, Eva, is that the process we used this last interim between the two meetings? I think that Eva maybe took the points out of the minutes and forwarded them to the leadership staff to make sure we were following up, and then was trying to make sure we were on top of that. Is
correct. I kind of wrote it down during the meeting and then followed up with folks individually. And what I have here from Dr. Trish's conversation with VPS was that at least one patient rep has been working 35 hours a week during the pandemic. And that person wasn't a chauffeur. It was outside of the executive role.
Okay. Tom, did you want Tom from VPS? Did you want to give a brief update, clarification for VPS?
I can do my best. I do know that the facilities would not let patient reps in, as that's been already discussed. Isaac in Brattleboro was there until July 15th, and Michael has been working up until the last month when he resigned about, 5 or 6 weeks ago. And Topher was taking some calls as well. At this point, Nate is back and working full-time and covering whatever needs to be covered, and we are in the process of hiring 2 more folks. But exactly the point was that, yes, there's been coverage. I don't have access to the data, but I certainly could put it, I know Amanda Elizabeth does, so we could probably generate that. I think it's already been generated and sent off to the AMH for the end of the quarter, last quarter. Anyway, I just wanted to add, because I know there was some concern about that, but under the circumstances, we've done as best we could. And there have been many phone calls. I do know that. There have been quite a few phone calls. Is that helpful?
This is Vicky. That's very helpful, and I appreciate that. Do you have any information on the periods during which both patient reps were furloughed? My understanding was that they were furloughed in early March, and that lasted until after Isaac left and after, throughout the period.
Isaac wasn't furloughed, to my knowledge, but he wasn't allowed in the facilities. No one was. Michael wasn't furloughed either, but he wasn't allowed in facilities as well. So I'm not sure the furlough applies as much as access.
Yeah, my understanding was that they were told not to access patients within facilities during that time, that they were given the choice of either accepting furlough or working on the pathways support line.
Yeah, Nate took that option, but Isaac and Michael did not, as far as I know, unless they've reported something else somewhere.
Thanks, Tom. I think that data would be great, and I think this committee is knowing if there are barriers that VPS runs into. Certainly, if those are internal, but also if there are external barriers from the hospitals in patient access to advocacy in any number of ways. I think this committee's been really committed to making sure that that is possible to patients in, always, but especially during this time. So I would just like to invite and welcome direct communication from VPS about anything related to that if anything comes up to this committee. And thank you for
Yeah, the
your work.
meeting we had with Trish and Morning last week, it was actually, it was very helpful. They are committed to helping us gain access if necessary, and also get our own equipment in there so people can have private conversations with us. That was another barrier as well. And I'm having a meeting actually this week with Elizabeth and Alex from the retreat to try and sort out where Topher left off with that process of getting our equipment in there and getting better access if necessary.
Yeah, that's great to know, because we had heard that there was some issue there and then had tried to ask DMH for clarification about that, and there was, somewhere along the line, there was not clarity. So appreciate you.
Well, the facilities were closed down by executive order, so it was all very clear they weren't letting us in, and I'm not sure we should have gone in either, really, during. But,
oh yeah, sure.
Yeah.
Absolutely.
Yeah. All right, I'll be quiet. Thank you.
Thank you so much.
On the access to technology question, I think last time I had presented the information that the hospitals provided about their different technology access availability on each of the different hospital units, and I think that as I understood the request, that there was kind of a request that we kind of investigate in a more detailed way with the patients on the unit to see what their thoughts were about this access. And so we looked into it, and I guess maybe I have kind of a non-answer, but we have different contracts with the designated agencies than we do with the designated hospitals. And what we have is not something that allows us to just kind of do investigations like that are more formal without a more formal complaint, and that there are formal complaint processes, whether it's from a patient directly or a family member or advocate on their behalf. But with those complaints, we need details. So for example, I think that there was a specific issue at VPCH with new software and net protection software. So that was something we were able to follow up on and get answers and make sure that was resolved and give feedback to the standing committee about. But what we're not able to do as DMH is to just kind of assemble different patient groups on different units to investigate or ask questions about things that have not been kind of gone through that formal process. And it's not that it's not that we don't think that might need to happen, but we were thinking that maybe there's different processes by which that could happen. For example, Disability Rights Vermont is on a lot of the inpatient units a number of times a week, and that there's other, maybe Fox, there were some other things that we had talked about through DMH that would be mechanisms through some of the peer organizations to get that information from patients directly.
Yeah, I think one of the other avenues to have that conversation would be the hospital advisory committees. Each hospital has their advisory committees, and in speaking with Emily Hawes, this type of conversation is a regular type. This is a similar type of conversation that would be brought to the advisory committee, and so I think that's another avenue that you all might be able to access to gather that information and to kind of tease out, what, if there are concerns, and what those concerns are, and then if so, then bring those to light at the individual hospitals.
And I think there's also a sense, not that this wasn't you know, it's not the, we have, you know, we have the more formal complaint process, and that does work because we do get complaints, and we do get feedback and concerns through Disability Rights Vermont, you know, on a pretty frequent basis, and you know, we look into things and we explore things and such. So I guess the additional feedback that those processes are in place and, you know, to some extent working, or as we see it, there, you know, we do get frequent feedback and information that we look into. So
this is Vicky. Go ahead, Monica. This is Vicky. So I had a couple questions. I really appreciate that information. My understanding is that by statute, the ultimate responsibility lies with DMH to ensure both that patients have access to that technology and that communication, but also that DMH is to ensure that each patient is provided with information on their patient rights and also the contact information for Disability Rights Vermont and I believe 2 other advocacy organizations. I'm wondering how DMH has been providing, what format they've been providing that information to patients during the pandemic.
I'm pretty sure we gave that information a couple of months ago. Eva, do you remember that?
Offhand, I don't, but I can go back to the minutes. I believe that was update Sarah gave. But yeah.
Is anyone offhand aware of how patients are made aware of their rights?
I mean, I believe they're provided with patient rights packets, and also that it's posted publicly on the unit, and that all the information you mentioned is posted publicly on the unit and given to patients on admission.
My understanding as a patient representative was that the information is not provided to patients upon admission. There were issues where sometimes some phone numbers would be posted like behind the nurse's station, or I would find some like under books. But since I believe the responsibility lies with DMH to ensure patients are provided with these materials and that their technology needs are met, does DMH do anything to directly ensure that, or has that responsibility been shifted to the facilities themselves?
I believe the facilities are in charge of their own, you know, patient unit rules, technology access, and technology types. And again, I don't have the specific details, but I do believe we got back to the State Standing Committee specifically about the inpatient units and how they were providing the information, both the patient rights information and the you know, the advocate information on the units. So even if you can, I don't know if looking at some of the past, I think it was actually maybe 2 to 3 months ago, there were questions about that, but we can make sure we follow up on that.
Well, I know that
if you have specific report of X or Y hospital not providing that, then let us know which hospital that has been at, and we can follow up appropriately with that hospital.
This is the same exact conversation we had last month. I know that because I'm looking at the transcript. Tom said the exact same thing. If you know of a specific hospital where there's a problem, let us know and we'll look into it. And I'll just read you. It saves me brain energy to just read the same thing that I said before. So the question is, what does it look like? What does it mean to have private and confidential access? Those hospitals say that they are doing that. Our follow-up question is, what does that mean? What does that look like? And it sounds like they didn't give you an answer to that question, which is fine, but maybe we can go back and get that answer because it conflicts with reports that we've heard. And maybe it's true, maybe they've made changes.
Can you tell us where those reports are from, Malika?
Please don't interrupt me. Can I just finish my thought?
Sure.
It sounds like based on what Tom's saying from VPS, there is still some sort of technology, some relevant technology issue that's not yet fully resolved relating to access to advocacy. So it would be really helpful to know more specifically what it means and what is actually happening. And I don't think that means an investigation necessarily. I think Vicki threw out the idea of just, trying to get through to someone there. And it's not the case that if people are not making complaints or grievances that there's no issue. I talk to people and my team talks to people at least weekly who have a very significant and relevant concern in the DA or hospital system, and they are not willing to make a complaint or a grievance because they're afraid of what will happen if they do, of retaliation. I can't emphasize how often that comes up. So I think that relying on patients who already have so many barriers stacked up against them to do the labor, which is often fruitless, of making a complaint is abdicating responsibility to people who you're actually supposed to be responsible to.
I guess maybe looking at it a different way, and I hear what you're saying. I can't start calling up random hospitals and asking to talk to patients and surveying them about their technology access. So, and I can ask the hospitals, which I've done, and I've had communications with each of the hospitals, and they all, say that they have technology access, that they have the technology access that the document that I sent last time, and that patients all have the availability to have private confidential access. And so if there's a particular hospital or unit or incident that there's a concern about, and that, I guess we need more details than me, contacting 10 or 11 hospitals.
We're just going in a circle again. The question to ask the hospitals is, what does it mean to have a private, accessible access to external communication? What does it look like? That's the follow-up question. We know that they've said that they do, and so that's the follow-up question. I thought it looked like you had agreed to follow up with that question.
So that's what I agreed to follow up on, and I guess I thought that I was following up on trying to see if we could get information from the patients about their technology access and what that looked like. I have information from all of the hospitals about what that looks like, and I can dig into my notes, but at one hospital they give a patient a tablet and give them a room, and in another hospital there's a room with a computer where they can shut the door. So I can see about specific notes from each hospital. I don't know if that's exactly what you're looking for, though.
This is Vicki. I believe we asked for policies from each hospital last month. That's my understanding.
I gave you the notes that I had from each hospital about that access.
I have a question I wanted to clarify. In Act 179, it says the Department of Mental Health shall develop and regularly update informational material on available peer-run support services, which shall be provided to all persons admitted or held for admission. And in the same section, it says that the Department of Mental Health will provide the contact information for Vermont Legal Aid, the Office of Mental Health Care Ombudsman, and the Mental Health Patient Representative. I'm wondering what informational material DMH is regularly providing, and if we can get a copy of that.
Sure, we can
Eva, can you add that to the list? Yeah.
Yep.
List of requests,
Exactly.
Sure.
I can. If you can come in an email, that would be even more clear for us, but I'll definitely write that down.
Tom, are you saying you sent us your notes from the facilities after our last meeting?
No, I believe I sent a document that was I don't have the title of it, but it was technology access, and it was before the last meeting. I can see if that wasn't sent, we can certainly send that. Maybe I just went through that verbally. I don't recall.
Yeah, my memory was that it was verbal, but I also miss things in my email all the time. So if that was sent out and has that more detailed information, that's great. Maybe
Okay,
Eva,
sure,
are
I'm
you
happy.
going to Okay, yeah. If you want to resend it, or Eva, if you have it and want to send it either way, I think that is helpful.
Okay, I'll either send it or resend it to Eva and she can distribute that. So I apologize if that physically wasn't sent.
Okay. It's there.
Thanks.
Dan, did you want to add something?
No, I'm all set.
Okay, cool. We're a little over on our time. Are there other questions that people have or updates that Fox or Tom you want to share?
I don't
Nope,
think I have
nothing to share
anything
right
else.
now. The only thing, just don't know if the committee is aware or not. The reason that Commissioner Squirrel unable to join today is that she had a death in her family and has been out for the last 2 weeks. Her younger sister was killed in a motor vehicle accident about 2 weeks, just about 2 weeks ago now. And so I'm expressing her regrets for not being able to be here today, but it was due to that unforeseen and pretty horrific situation.
Please send condolences, Fox, if you would.
Yeah. Absolutely.
I will do that.
Thank you.
I will, Dan. Thank you.
Thanks.
All right.
Great.
Well, thank you, folks. Appreciate your time.
Thank you so much.
Thanks, Fox. Good luck with
Thank
everything.
you.
Take care.
Yeah.
Thank you.
Thank you.
Okay. So the next item in our agenda is CSAC document review. But before we move on, do we have, is there any clarification we need to make about our recommendations in response to that update?
There was one issue that an area of concern that came up to me that I just want to mention to the committee, and that was relying on Disability Rights Vermont to inform DMH of individual complaints about communication. When I spoke with Mary Postemski from Disability Rights Vermont back in December, they said that she said that their organization was shifting to sort of large more like large class action or group issues, and that Vermont psychiatric survivors, they were hoping that Vermont psychiatric survivors would be doing more of the individual representation. So it just seems like that would not be the appropriate avenue for them to get that information. So I just kind of wanted to put that out there since I'd heard that from Disability Rights Vermont.
Thank you.
This is Lynn Cardozo. Can I just say something quickly?
Please.
Oops, hang on. Just perhaps a thought to invite Mary or somebody from Disability Rights Vermont. So when I mentioned my professional position as the director for the Vermont Communication Support Project, I work under the umbrella of Disability Rights Vermont, but am not doing the work that we're discussing right now. So you'd want to ask AJ or Mary to come on board, but maybe you could have them be invited for a part of the meeting in the near future. I think they could clear up those questions quickly.
Thank you, Lynn. I think that's an excellent recommendation. I know Mary goes directly to the retreat. I would be in favor of asking her about patient rights during the pandemic. She would seem really situated to have that information.
Agreed.
Yep. Good idea.
should we make a motion and add that to?
Kate, I have a
Go for it, Kate.
I'll let Vicky finish before I jump in.
Oh no, I'd like to hear what you have to say, if that's all right, Kate.
Well, no, I didn't realize it required a motion. I was going to talk about something else before we moved on too much. I think that's a very good idea.
Oh, okay, sorry. Yeah, I was wondering if we should make a motion and if any possibility of fitting this into September, or if this needs to wait till October to invite Mary, and if that's something we feel prepared to vote on.
This is Lynn again, and I'm wondering if maybe deciding on who it is to be invited should be maybe discussed with AJ, because I mean Mary does go into the retreat, but there are other people working up north, and I just the thought that you might want to decide to invite somebody from Disability Rights Vermont, but maybe have a conversation with AJ to figure out who would be, if you're going to have one person who would have sort of the most encompassing information with regard to this conversation.
AJ and not Ed Paquin, Lynn?
Well, I'm just, or Ed or AJ.
Another possibility is that if there was someone on the committee who had the capacity or interest to sort of talk to any or all of those people, maybe even join a staff meeting or something like that and get clarity from them and then bring that back to the committee. That's another possibility. It might be easier to do on a shorter time frame.
Sure. I mean, staff meetings happen all the time, so I'm not saying sure. I'm just saying as far as that as an idea, and just to be clear, I wasn't specifically recommending that AJ be invited to the meeting or Ed or Mary or whatever, but just have a conversation as to who that person should be with either Ed or AJ. But if you're also now talking about maybe a representative going to a staff meeting, then I guess I would suggest that somebody just have a conversation with Ed. He's chief of the staff meetings.
This is Vicky. I was intending on reaching out to Ed anyway. I'd heard that he has some concerns about the Middlesex, the new facility, and I was planning on reaching out to him. I would be happy to speak with Ed and anyone else at Disability Rights Vermont who'd like to speak with us. And I know the VPS meetings are public. I could sit in on one of those, just kind of compile a report to kind of give a brief update at our next monthly meeting.
Can I step forward momentarily? VPS board has given me the responsibility of being a liaison between the listening session and the VPS board. So in that sense, I can reach out to other board members. We have a meeting later today to ask any questions that might seem pertinent to this task.
Cool. Thank you.
Anything in specific other than whether or not patients have had access to technology and the ability to reach out to advocacy such as Disability Rights Vermont?
I'd be interested in knowing what the coverage has been in the hospitals during the pandemic in terms of how people access notified of access, if there's been any changes in the rate of people accessing reps, if there's been any interruption in inpatient reps or any patient reps furloughed and unable to perform their duties. like what the dates on that have been, because I know right now there aren't trained patient reps,
So-
but kind of what we're on the services.
So in some sense, Tom briefed us on that, in that Isaac and Michael have left, but we still have one of our patient representatives and Nate covering where he can. But you're looking for specific dates of
My
when
understanding
access
is that
to inpatient units was stopped, and then it seems like you already have that information, Vicky. But
well, Nate is part of the Community Links program. He's not funded by DMH for patient representation. My understanding is he does not cover the retreat or VCPH. So I'm kind of wondering who was providing patient representation to the retreat and VCPH, and when that service was interrupted, and if there were any significant changes in patients accessing those services during the pandemic.
I was a little uncertain about that myself. My understanding was that Nate works in Rutland with Rutland Regional Mental Health.
Maybe
Okay,
it would make
so-
sense. Maybe Bert and Vicky, you can connect about this outside of the meeting, about what exactly are the questions, where the need for clarification is. Does that work?
Yep.
Cool.
Thank you.
So Vicky, I can just plan on including. Okay. Vicky, I can just plan on including you in an official email this evening.
Yeah, that would be great, and I'll email you my specific questions just right now, so that's kind of clear and doesn't take up any more of our meeting time.
Okay.
I appreciate you.
That's helpful. Thank you for understanding. I'm a little bit running a little bit low on energy right now, so thank you.
Oh, I really appreciate you looking into this, Bert. Thank you.
Of course.
Kate, did you have something you wanted to say?
Yeah, I'll try to be quick. One, I was wondering, Vicky, were you suggesting did I garble that mix up that during the listening tour that patients were asked, or are you directing are these questions still being directed simply to agencies? That's my first question. And my other thing is I was wondering, we didn't ask about the response, whether the letter to the commissioners had been received. So I didn't miss that point also. Two separate things.
Okay, so the letter to the commissioner, I ended up looking over the language, and so much has changed since the last draft was created in November. Back then, we were requesting permission to do our own minutes, to put things on our agenda. Several things that have been resolved since then. So I felt that with the edits I needed to do to just bring it up to date, I wanted to run it by committee members before I sent it out. So I have sent that out to committee members. I think I've heard from a quorum of committee members that it's okay to go ahead, that they're okay with the new version. But since I got those as of yesterday, I thought I'd just mention it in our meeting today, that I'll go ahead and send that out unless anyone has objections. I don't think we need a new vote for the new version, but I wanted to run that by members.
No objection here, Vicky, whatsoever. I did notice, I read that this morning. I noticed a potential typo. Other than that, I think it's a great revision.
Oh, great. If you can let me know what that typo is, I will change it before I send it out. I appreciate your oversight of that. And Lynn, what was your first question? I'm not sure that I caught that.
No.
So you just, I think you addressed Lynn, but I didn't.
Were you?
I think it was somebody else.
Kate.
Oh, sorry. Kate, I'm sorry, Kate. I'm sorry. I missed that.
Yeah.
What was your first question? I'm sorry.
Yeah. My first question was, had you that asking patients directly who were involved in the listening tour about patient reps or access, those kinds of things. Were you suggesting that, garble that?
No, I was not suggesting asking. This was separate from the listening tour. I was just asking about the patient representation that's been provided during the pandemic, not about the listening tour.
Thanks.
Sure. Thanks.
Yep. Thanks.
Okay. Awesome. Thank you, everyone. We should move on to CSAC. And my personal hope is that we can finish this, even though we're starting late, a little early, because I know that we have a lot of people here from the public, and I know, like I said, someone else will be calling in to share about an experience in the hospital and ER. So I want to make sure that doesn't get too crunched. I think the way we normally do this is we sort of like name our questions and note the page number. If there is a relevant specific page number in one of the reports. We start with the designation report.
Can I make a suggestion, Malika?
Yeah.
For the agency designation report, what's relevant in that report are any of the items for which the under meet standard there's no.
Yeah.
My suggestion is, unless people do have specific questions, is that we just blanketly ask the question that for each of those items where there's where it says doesn't meet standard, they just give us an update. And Eva, some of these may have already been taken care of anyway, right?
Yeah, they saw this report because Dale shared their version of the report, I think in April or May. And so they've started to address the bylaws issue that was in 4.2 governance.
Right.
And they've now seen the 4.7 feedback, but they won't be required to create a plan or next steps until we have a final decision from the commissioner about what level of designation they're getting. So they may have started to work on it, they may not, but they have seen this report at this point.
Okay, great. Dan, I really like that suggestion, and I think if we follow that, we can just move on from that report and just get an update.
You're right.
Yeah. And I think Eva also had sent out like some of the questions that we commonly ask. I quite like that as well. It's just sort of like boilerplate if we want to know about these different areas.
I thought that was a great list of questions, Eva.
Yep, I agree.
Yeah, and that hopefully will cut down on some of our work. Like if those are questions we want to ask across the board, as well as update on areas where they don't meet the standard, we probably shouldn't and don't need to have too many other questions. Yeah.
Yeah, I can add those list of questions. Are there any questions on that list that you don't want included for CSAC?
I'm just pulling it up.
They've definitely answered especially the questions about stakeholders and community presence. I mean, that was pretty well delineated in the report.
I read through the site visit report, and it seems like there's good community collaboration. There's a whole list of community partners. I count one, like 6 or 8 of them, including Department of Mental Health, DCF, Voc Rehab, kind of standard statewide agencies, but also some more local stuff, including Mountain Health. So anyway.
I found it interesting. Oops, go ahead.
Go ahead, Thelma.
Oh, I was just going to say that, I mean, I'm a peer worker there, and they didn't really have much about peers at all in the report, but so these questions are good ones to ask them. I'd like to see what they say about peer services.
Yeah, I did have a comment about I have a few comments about the questions now that I'm looking in a little more detailed way. About peer services, I think, a general description about peer services. The first question is great. On the second one, and any other place where we're talking about peers, I think to avoid confusion and ambiguity, if we could be specific about what peers means instead of using the word peers, because people use that to mean lots of different things. So are your peer support staff or something like that maybe would be more clear. And the question about zero suicide, I'm sure this is a question that we came up with at some point, but it doesn't quite make sense to me. It says, what are the values of the agency around zero suicide? I would maybe favor just changing that whole section to suicide. What is the agency's current efforts around suicide prevention or something like that?
I think that's a good rewrite, Malika. That question may have been generated from a little bit of inquiry from me, but I think also we've had previous committee members who are very much passionate about zero suicide. I'm not nearly as well informed as that individual, but anyway.
And it looks so different in different places.
I like that question, Malika, because it's open-ended and they can really talk about what they're focused on instead of saying, well, we do zero suicide or we do this or we do that, but they can talk about what they do.
Sure. What modalities do you utilize to reduce that?
Yep.
Right. Thank you.
And about the local program standing committee, small thing, how is the local program standing committee mutually beneficial for your agency? I guess I'm not sure exactly what the mutually beneficial piece is, but I think what the question that I would want to ask there is what input from the local program standing committee have you acted upon?
Or followed, yeah.
Yeah.
Okay. Does it make sense for us to refer to the site visit report had a fairly extensive list of dialogue and concerns and stuff that was brought up by the family youth services as well as the adult mental health? Community youth and family services as well as the adult mental health. It was fairly well documented discussion from the site visit, but anyway. Does it make sense to think about the concerns that staff brought up concerning budgeting restraints because of differentiation between substance abuse and mental health, as well as some of the violence that was mentioned at the group home and the steps that the agency has taken regarding that?
It was interesting that they mentioned, I mean, I don't have the page number in front of me, but they mentioned Robinson House and violence, but there was also major violence at Hill House that happened that caused a lot of trauma for staff as well as other clients too.
Okay. Agency listed,
I don't remember.
Or staff listed. Okay. Other staff mentioned open dialogue, debrief, crisis prevention, that kind of stuff. police response, Narcan, and IPS. It seems like there's a certain population that staff has struggled to support.
Yeah, it would be great
I
also
also
to
need
get it'd be great to get an update in general about open dialogue, and how that's going. I'm sure they'll have updates about that. Also, one question that I think I would love to have on this question themes document, sort of across the board, is around the prescribing practices. What does informed consent look like, and how are they ensuring informed consent? And what have what's their capacity, or what sort of capacity building have they done to support people in getting off of safe drugs when they want to be able to do that safely?
Another thing that it was mentioned, and you'll hear about this, I guess, when they come too, but basically they opened the MyPad. They got a house, they bought it, and they have one client in it so far.
It would have had to been in the last month or so, huh?
Absolutely.
What about some of the efforts to coordinate care with Porter Hospital ED?
Yep, that's been a...
Say again?
Oh, that's been a struggle. Porter has a new head honcho person, so they're not on board like the other person was at this point. Yeah. But they're still in communication with Porter, so I think that would be a great question.
Yeah, I agree, and I think that question should be as open-ended as it can be. Is just talk about the relationship and what's going on, and in the emergency department, and how CSAC is working with whatever issues they're having.
Okay.
Did you want to go through the other two documents, Malika, quickly?
I'm personally not interested in going through page by page or line by line, but I think we could, whatever people have for questions on them.
Can we just address the site visit?
Yeah.
On page, I'm going to go not page by page, but on page 4, under supervisor, under supervisors at the bottom, and I'm not going to read it all, but there's a section where they talk about supporting adults with complex needs, and there's several bullet points under there that it's not really clear to me exactly what they're saying. They're talking about client acuity getting higher and not meeting patient threshold, and previous traumatizing experience with clients is making staff hesitant. So my question would just be to elaborate on what they're saying under supervisors part D, supporting adults with complex needs. That would be one.
Okay.
Yeah, you're going
to get to that. I hope to hear that the MyPad is.
You're going to get to that through the Robinson Hill House. That's what they were referring to there.
Okay. Yeah, and generally, these would be a lot of these issues would really actually very fit under the list, the generic list, but there seems to be issues with their electronic health records. What's happening, how they're doing with that.
Oh yes, I just love Credible. They've been working really hard trying to get on top of everything, but it's also a pain in the butt. I'll be the first one to admit that.
Yeah. There also seems to be training issues, and maybe they can all be lumped under on that page. The training of staff, supervisors, I think, as well as the local programs committee, not only not necessarily getting adequate training, but being involved in helping decide what trainings are needed.
And I think, like, I don't know about some of the other agencies, but one of the things that's been happening is a lot of the training now is done by Relias. So you just do this damn training online.
Yeah. Right. Yeah, that's a good one, Thelma. It would be interesting to hear more feedback, because we've been hearing that Relias, like, it seems like it's been implemented within the last year or so. And
yeah,
at least from what I've been hearing, it's kind of mixed feedback.
yeah. I mean, they have some really good trainings, and some other trainings it feels like a waste of time.
Yeah. Another issue that I think definitely comes up in a number of places, and again, a broad open-ended question about psychiatry services. What's being provided, and feedback about issues relating to services. I think there may be a vacancy issue there. Oh, and speaking of vacancy, has the new executive director been hired? It wasn't clear from these documents.
Oh yeah, no, she was hired. She's been there. She's been there a year already.
Okay.
Oh, what the heck?
It must have been one of the dated documents which talked about the search for ED, a new ED.
No, she's been there a while now. I think it's been over a year. Rachel Cummings is her name.
Also, still in the site visit on page 8, towards the bottom. Again, I'm not suggesting I read all the line items, but at the bottom, under the title "Feedback Shared by One Participant," actually it says item B, some clients shared suggestions. So there's a little inconsistency there between the title and item B. But I would just like them to elaborate on this. There's 5 different suggestions. Just elaborate on those suggestions. Whether they're implementing them, and if so, how's it going?
You're talking about the site report. Is it under local program standing committee discussion or with staff?
No, I'm talking about on the site visit, page 8, the top of the page, it says client families. And about 2/3 the way down, there's a title that says feedback shared by one participant.
Yep.
And under that B, it says some clients shared suggestions they have for CSAC, which some clients is inconsistent with one participant, but I'm just concerned about the suggestions, which are alternate therapies, microloans, autism training, and a number of other items.
Okay.
I think one of the things that was concerning to me, and I actually know the history behind this, but a participant shared that they fired their treatment team a year ago and are concerned it took a long time to get reconnected with care despite weekly meetings. It took almost a year for that person to finally end up getting back to his same old team again, actually.
So do you want to pose
I remember that comment as well.
Do you want to pose that as a question, Thelma, using that as like a case study? Talk about how that, that is handled specifically, or maybe more, the issue is more in general, how that would happen?
Well, this was more specific to one client, but it just surprised me how long that took before he was able to get services again.
Yeah, so I guess it's really a broader question of, this came up, and at least in 1 or 2 other places, they talked about patients who are their clients and then they're not, and then getting re-onboarding, streamlining that process. So maybe that's the broader question, is what they're doing in terms of ease of access for residents in that community to get back into the
Services.
DA for services.
Yep. I don't want to ask that question though, but somebody else can.
No, I'm happy to. Yeah, and I think, Malika, you asked the question about medication, and on page 13, they talk about appropriate use of medications. It's like the fourth box down. I would ask that they also address, in context of your question about medication, Malika, just address these specific issues they talk about, because it says right here, for example, efforts to avoid multiple medications, which I'm very pleased to see, and I'd like to hear more about just what they're doing.
An incorporation of non-pharmacological services and interventions is on that page too.
Yeah, absolutely. That's a great complimentary question as well, Thelma. I totally agree.
I got a question that's totally off base. Since I'm looking at this, I'm going to ask this question real quick. Is there anybody that's using ketamine? I know CSAC isn't.
You mean, are any of the DAs prescribing ketamine? Or hospital?
Yeah, I was just wondering. It's totally off the wall. You don't have to answer it, but I was wondering.
Well, it's not off the wall. It's probably not germane to this, but I'd be really interested to find out the answer.
Yeah, I would too.
I have a little information about that ketamine thing. I looked into that because I have some issues. Do you guys hear me?
Yes.
Hello?
Hello?
Hello? Hi, can you guys hear me?
Is this Greg
I
talking?
don't know if I'm...
Greg, I can hear you, but there's some kind of music in the background.
I was the only place that I found that you could get to go to get a dosage is over in Albany. They have a clinic over there. But as far as that, anything in Vermont, I don't think so.
Thank you.
Welcome.
I'm done with the site visit, by the way, in case anybody cares. I'm now looking at the agency review report, but I'm going to let everybody else ask questions, and then you can loop back to me.
Maybe you're the only one.
Okay, well, I'll forge ahead then. Actually, this actually, I would say, should be included on the broader list, the generic, which is the whole issue of housing and what they're doing across the DA when it comes to the housing issues for their clients and patients, whether it's the CRT patients, the AOT, their clients who are coming out of inpatient or frankly, other residential. So it's just the broad issue of housing, as respects their different programs and what they're doing. And I guess you mentioned MyPad as an example of something, creative and progressive, which is great to hear more about.
Yeah, that's great.
I mean, one of the things that's interesting in the Addison County area, and this, I guess this would be just a generic question about housing, but they've been talking about building little houses. And the housing person who works CSAC has been in the process of, has been in those discussions.
You're referring, Thelma, to the quote unquote tiny house?
Tiny houses, yep.
Yeah, Washington County has at least one. I think they have two that's up and running. And as far as I know, it's just been successful to date.
Great.
There's another issue, and this is actually, if anybody cares, it's on page 10 of the HU review report. They have in these review reports, as everyone has seen, what's called a SWOT analysis: strength, weakness, opportunity, and threats. One of the weaknesses, and this, I think this is under the CRT program, relates to it says to continue to work on being trauma informed and clarify specific trauma treatment approaches. So, the question is, what are they doing in terms of work on this issue of being trauma informed and addressing trauma treatment? And I know this comes up elsewhere as well.
Yeah, I think that's a good question, because I'd like to know too.
And then consistent with my earlier suggestion about the agency review, not the review report, the what's it called? The designation report. For each of these sections, there at the end, for example, there are I think there are 4 sections. There's CRT, AOP, ES, and then overall. And at the end of each of those, by department, there's a set of recommendations. And again, I would, I would ask them to address those specific recommendations, many of which are redundant, so they can address them in broader ways. But just making sure when they are giving us updates that they touch upon these specific recommendations.
I think that's a good point.
I have a question. They mentioned providing services in police settings and ongoing networking with police departments. This is actually, I think, a general question we should be asking.
Right.
Which is, in what situations do they rely on the police, and are there any plans or efforts to reduce situations where they're initiating police involvement?
And alongside of that, Malika, they discuss at somewhere, and I think it's in the agency review, things that they're doing relative to Team 2.
Uh-huh.
And I seem to recall they talked about that in terms of an accomplishment. So hearing more about what they're doing in terms of implementing the Team 2 concept.
Yeah. There's actually a Team 2 training coming up that I know that they've been working on.
On page 15 of the agency review at the very bottom, there's something there that I'm very eager to find out more about. They talk about increasing positive outcomes by reducing hospitalizations through non-categorical case management with special attention to housing, employment, so forth and so on. I'd love to hear more about what they're doing specifically in terms of this objective to increase positive outcomes by reducing hospitalizations.
What page are you on?
I'm on the agency review report, page 15 of 34 at the very bottom. It's the first paragraph under quality domain, outcome results of treatment.
Oh, okay. There it is. I found it. Thank you.
Yeah. And at some point, Malika or Bert, did we want to talk about Bert's, Bert, your suggestion or your comment about the volume and complexity of all these materials that we have to go through?
Dan, I was only referencing comments I heard months ago from at least 2 committee members. It can be a lot to go through 60 and 70 pages of documentation. I'm still working on reading the SWOT tables and that kind of thing, so I'm in some sense still familiarizing myself with this process. Sometimes it can be a little bit challenging in that my specific clinical experience is limited. So as someone with mental health challenges and lived experience, it's an important thing, I think, to collaborate on this. And I think our question and answer session a month prior is pretty good. But I wonder if we can plan on being a little bit more deliberate about how we might break up the questions regarding, reviewing the great work that Eva has done a little bit more thoroughly, so as to be, so as to complete this task with as much sincerity and accuracy and diligence as much as we can. If we want to ask the Department of Mental Health to be included on some of the site visits, maybe during the local program standing committee discussions, then I think we need to be assertive about how we go about it. So that's all I was really meaning to say by the email. I wasn't meaning to include belittling language or anything offensive in that. I don't think we have. It's I think an important thing to think about. That's all.
No, Bert. Go ahead.
I just want to say that as far as I'm concerned, these reports have gotten a lot more streamlined than they used to be, and they're a lot more reader friendly.
Okay, that's
Right.
good for me to know. I've only been around a year and a half or so.
Yeah. However, Thelma, you and I we've been on the committee for a while. There is still a lot of material, and particularly with all the acronyms. I would just, tell not only the newer members, but even the prospective members to don't be concerned if you can't absorb everything in the early months. Over time.
Oh, of course not.
Yeah, over time, the format and the questions are particularly the longest report to review. It's a fairly standard thing. So, if you once you've reviewed enough of them, then it becomes easier and easier. And then the other comment, Bert, relative to your email, I just wanted to say, each of us brings a different skill set, experience base, and strengths. And I think that, the strength of a committee like ours is having diversity of
Sure.
across all dimensions. So some things, like me, I'm a financial data analyst by training, so I like the numbers. Other people, then the eyes glaze over. So as committee members, my suggestion is, review the material and focus on the things that jump out at you, and don't get bogged down if some things seem overly dense or not as clear.
Bert, were you given the list of? There's a list. I don't remember the last time I saw it, but there was a list of terms and definitions. Did somebody give you a list of terms and definitions when you first came on?
That applies specifically to the SWOT tables, the pie charts, and the data is compared across the state and that kind of stuff, or?
Yeah, it broke down acronyms. Do you remember that, James?
Okay. I mean, that would be helpful, I think. I'm fairly familiar with like AOP. What is it? CYFS or CFYS? I mean, some of them I've gotten to be a little bit better at. I know CRT well because that's where I've had my mental health services. But yeah, I think that would be helpful for sure.
Yeah, Eva, you might remember that list of acronyms is attached to one. It's one of the generic documents that new members get.
It's not something we've been sharing up to this point because we've tried to write our reports with all the acronyms spelled out. But what I'm hearing from this conversation is that there's times, especially when we're talking, when we still use acronyms like CRT, AOP, CYFS. And so it sounds like it would still be helpful to be sharing that with new members. And I will look for that document and then share it to both prospective members and current members.
Thanks, Eva.
This is Vicky. If I can just jump in.
That would be helpful. Thank you.
If I can jump in real quickly, this would be a great document to have on our shared drive. And also, I know it took me a while to kind of I had a lot of questions when I was a new member to kind of get the lingo and the processes down. If any new or prospective members have anything that they find confusing, or if any members find some information that they're like, this is really helpful, I would love to compile a shared document that maybe we can kind of collaborate the information that's been most helpful or that we have the most questions about, and just have kind of a FAQ for the committee, if that's possible.
Oh, that's a great idea.
Yeah.
Cool. So if anyone has that info, like, anyone who sends anything to me, I'll compile it into all one document, if that's helpful.
Great.
Thank you. Yeah, I think that there's a lot to think about here in terms of accessibility, and I personally feel like it's totally fine if not all of us read these documents, or even frankly if none of us read these documents and we just ask the questions that we're interested in. I think that that's all okay. And I think too, it's a plug for being able to go on the site visits, because that's another way of gathering information and knowledge that doesn't depend on like reading long documents, which is not everyone's bag.
Right. Respectfully.
And
Go ahead, Bert.
I was just going to say that is similar reasoning for me to have gotten to the site visit report and to read through that quite thoroughly, but I've stayed away from the SWOT tables, at least for CSAC, but I will look at that surely before our next meeting anyway.
Yeah, respectfully, Malika, I think as a committee member, everyone has an obligation to at least attempt to review the documents. I don't expect most people review everything page by page, but I don't think we should. I don't think we should be giving people permission not to attempt to at least skim the documents.
Oh no, it's we can't redesignate an agency just based upon a conversation that we have over 40 minutes, especially because the procedure has taken who knows how many man-hours from the DMH just to do the site visit and then the final reports too. I mean, that wouldn't be fair to Eva's work, or I don't think it would be a viable procedure for the committee either. So I'm not meaning to be critical, Malika, but
no, it's fine. Like, I just don't think this is actually, like, I don't think we're actually doing anything when we're, besides gaining information. I think we can sort of direct our information gathering. But anyway, it's sort of a bigger conversation. Yeah.
I think we would be better focused for the time being to continue with establishing questions, honestly.
Yeah.
Yeah, are there any more questions that people we haven't covered yet?
Okay, so we sort of changed the zero suicide to the agency's efforts regarding suicide prevention, right?
Yeah, making it more sort of generic, I think.
Yeah.
Yep. And then there was a question, not a housing question in here.
Yeah, we had a housing. Another issue that comes up at various places throughout the document, and my interpretation, and it's about elder care. My interpretation is that there's ambiguity and maybe not as much focus on the elder care or geriatric population. So the question just for me would be broadly, what are you doing in terms of elder care and specifically addressing the needs of the geriatric population, which I guess I'm probably part of now, or at least getting close to.
That's a good question.
The other broad.
I think so, at least from the site report, I would agree.
Yeah, the other broad stroke question, and normally I would, as seasoned members know, I would go through this in excruciating detail, but I would just ask them the broad.
Not you, Dan.
What?
I said not you.
No, not me, never. I'll shortcut my detailed drill down by just asking them the broad question. In terms of all the charts, their summary of current statistic data and the pie charts, if they could look at those and determine what they think are the outliers, and then just talk, whatever they think is important, talk to, why there are outliers. Why, like their data, for example, on page 18, on the statistical data, under administrative discharge, the statewide data has lost contact at 12%, which I assume means when they get discharged, they whatever the process is, they aren't able to keep in touch. But statewide, the DAs on average lose contact 12% of the time, whereas CSAC over the last 3 years, it's ranged from 26 to 38%. So that's just an example of where the data shows that they're statistically significantly different from the statewide data.
Yep.
So
what does that mean to them?
Right. What does that mean to them? And
well, thinking qualitatively, Dan, thinking about CSAC has Evergreen. There's two communities, the Washington County Mental Health Community, I've forgotten what it's called, and then another way, HCRS, there's what, the Hive, and then another community. So that makes 3 or 4 of 10 designated agencies that have community centers and maybe a little bit stronger kind of peer workforce. I wonder if that affects the numbers statewide a little bit.
Yeah.
So when we look at Bennington and then Northeast, what was it, NCSS, both of them were struggling to establish a more robust kind of peer support workforce and offerings, but seemingly with maybe mixed reviews, you could say. But
yeah.
So Eva, are you going to? I mean, like before, are you going to send out the list of these questions to them ahead of time?
Yeah, first I'm going to send it out to the committee, and I have a rough list right now, but I'm going to try to finalize it before the end of this week and send it out to this group. And then hopefully get feedback from y'all if there's anything you want to change or if I didn't capture anything appropriately, so that we can send it out to the agency a week before they visit.
Okay, thank you.
Awesome, thank you so much. Does anyone have any final questions to add, knowing that you can also add them over email if you think of them later?
Ask them to explain the chart at the bottom of page 22.
In full statistical detail in a way that is professionally adequate, concerning various different normalcy curves or outliers and as such and such and such.
It's a chart that actually I think it's about a performance measure for for the emergency services division, and the performance measure is clients will have a decreased need for inpatient care. So not only is the chart confusing to me the way it's laid out, but I'm also really interested in the answer.
Especially because there was, well, Dan, I think that's a viable question, and from reading the site report, there was some worry about the acuity of clients increasing and needing a level of care more so than inpatient and maybe some longer-term residential options. Hopefully MyPad managed to at least initiate that kind of demographic need, I guess you could say.
So Malik and Eva, I won't take up more time, but if I have any more questions, I can just send them to Eva.
Yes, please.
Yeah, thank you so much.
Okay.
I was hoping to do the same, so.
Yeah, anyone I think is welcome to do that.
Okay.
Sure.
Can we move into public comment?
Sure.
Fine by me.
Cool. All right. Members of the public, this is your time. And I would like to ask committee members because we probably have a lot of things people want to say, to hold off until the end if there is even time for responding.
Thank you, I would agree.
This is Eva. I have a public comment from Beatrice Birch, who had to step off a little bit early. She just wanted to say she appreciates everyone's concerted efforts in the standing committee work.
Hi, this is Greg. I just have a couple of comments and a question. First of all, I'm sorry I missed last month. I had a whole day of medical testing I had to do, but this is such a really good eye-opening meeting that I got to see you guys work through. It's a lot of good work out there, and that I can see that you do. I've been looking for something like this for a long time. I've tried to get some peer stuff going a little bit more down here in Bennington and that. I actually does. So what my question is does the committee know that there is a 3-bed locked psychiatric ward at the hospital in Bennington?
I don't.
I didn't know that.
Okay. Well, I've done quite a bit of work. Started back with Wilda when she was first taking charge. We had I wrote a letter called Psycho Hell at hidden away at SVMC, and it made the front page of the paper there, the Counterpoint, and also my second one. So I can see that being a member of this group would greatly enhance my efforts of trying to go get something going up there. I had the person that I dealt with in the beginning was in charge of the nurses, in charge of that area. She left, and her second in command ended up taking charge of that, and I ended up getting kind of pushed out of there. So now maybe this is a possibility of, being able to get something going back, because I re-experienced what's happening there. It's a long story, but anyway, it's not what it was before this other person left. It's gone way downhill, and the care that the patients are getting there, it's very poor. That's all I got to say right now. But I know that it could be revitalized. I was even given a hospital volunteer pass so that I could do the work. I had to put together a whole thing to satisfy Dartmouth, because they're a magnet hospital with them and everything like that. So, but anyway, thanks for letting me sit in today, and everything was really good to see how it goes.
Thank you, Greg.
That's it. And I'll be definitely putting in my application.
Awesome.
Okay, that's it for me.
Great. Other comments from the public?
Excuse me, I have another question. Is there I'm not sure of who I should contact or if there's somebody that I could ask questions to, because the only person I have a phone number contact for really right now is Malika, and I don't want to be bothering her, especially, when I wasn't sure about who to call, and I called her just to let her know I wasn't going to be in last month. So,
Greg,
yeah.
Greg, and anybody else who's a prospective member of the public, I can give my email address and telephone number, or Eva. Yeah, I'll do that because some of you aren't on an email distribution. My telephone number, feel free to call me with any questions about the committee. And the telephone number is 860-558.
Wait, excuse me. 860.
860-558-5341.
Okay.
And my email is dantolle, DANTOWLE,
yeah,
at comcast.net.
Okay. Thank you so much, Dan.
You're welcome.
This is Sharon Levinson down in Guilford. I just want to say what an impressive amount of work you people do. Wow. And okay, Vicki, you are the most organized human being I've ever come across in my entire life. Ever. You should start your own company, how to organize the world. Very impressive. Your efforts, everybody, your efforts are just so appreciated and so needed and clearly making a difference in Vermont. And I applaud you all. It's very awesome.
Thank you.
You're welcome. Thank you.
And thank you so much for being here. I just wanted to let you guys know I had a conversation with Sharon over the phone this past week, and we talked about the committee, and I'm excited that she's a prospective, looking into becoming a member.
Thank you.
Yeah, that's great. I'm told that Heather is here and may want to make some comments.
Hi. So this is my first time. I'm a little, this is a little awkward for me. But I guess I just want, thanks. I guess I just wanted to share a couple things about my most recent hospitalization experience. About a week and a half, 2 weeks ago, I guess it would have been July 30th. I was at Mount Ascutney in Windsor to be evaluated by crisis, and had a very rough experience. Crisis was okay, but the hospital experience was not. I went through a lot of, I was not given an opportunity. I was there from Thursday to Monday while waiting for a bed. Was not in good physical condition when I got there. Hadn't showered in 3 or 4 days probably. Friday night I asked for a shower. Was told that they were too busy to help me. That maybe Saturday I could take a shower. But I was given a washcloth and a towel and told I could go into the restroom and clean up. All they had for soap was the hand soap dispenser on the wall, which was foaming soap. And I had to ask for a clean Johnny because I had spilled my dinner, which was spaghetti, and it was pretty obvious that, it wasn't clean. Saturday was a repeat, as was Sunday. Nobody had time to take me for a shower. By Monday, by the time my retreat bed opened at the Brattleboro retreat, I was
not smelling very pleasant, and I was very humiliated. I was not offered any kind of toiletries, any deodorant, any powder. I'm a big girl, and I was a little chafed and sore. It was a long, lonely visit. The nurses were pretty much too busy to talk. The security guards and maintenance men and nurses were often arguing as to whose turn it was to babysit me. Somebody had to sit outside the door at all times because of my, it's standard procedure when you're there as a psych patient to have somebody sit outside your door, which is kept wide open. And they're supposed to watch you, but they don't really. They play on their phones and read and whatever. And I have, my own ways of knowing that they didn't watch me. We'll put it that way. And there was a discussion, I believe it was Friday morning, about 4 o'clock in the morning. There was a male patient in the room next door, and the security guard and maintenance man were talking about how, you can't say anything to these patients because there's already so much wrong with them, and they were going on and on about, what kind of people we were and how, these frequent flyers have so much, and they were just really making me feel less than. And that was just at Manascutney. And once I got to Brattleboro, things didn't improve. So, yeah, it was pretty rough.
I am so sorry to hear that.
I'm hoping maybe by sharing things as much as possible, even though it's really humiliating, that maybe somebody else won't go through as much of the same.
Thank you.
Exactly.
Thank you for sharing your experience. I'm sorry that happened to you.
Right. But you're not alone. Being someone who's been through the emergency room process, I can't disagree that there are a lot of problems. Which makes me ask the question to DMH: how much data is specifically gathered, feedback, whatever, about patients that have been in the emergency room for more than X, whatever, for more than 8 hours or 12 hours or whatever?
Well, VPS had an ED wait time survey. I can't remember the name of the Vermont bill, some 285 maybe. The legislature asked for data collection regarding mental health services. So that was a year ago at least. Yeah, I'm not supposed to be talking, Malika. I'm sorry.
No, that's okay. I was trying to interrupt before, and I realized I was on mute. This is public comment time, and I want to keep it as such if possible. Heather, I don't know if you were done or not. If you want to share anything about your experience at the retreat, you're welcome to. Obviously, no pressure.
The retreat wasn't pleasant either. Tyler 2, I don't know what, people know about that, but it's one of the worst places that I've been at. Everything is locked up. You can't even get a drink of water without asking staff. The kitchen is locked. The bathrooms are locked. I'm told the showers are comparable to prison showers by, people that have been in prison say it's just like a prison shower. It's just a spigot in the wall with water coming out. There's no shower curtains or anything, of course. And you have to press the button on the wall to keep the water flowing about every minute and a half. There's no place for everybody to eat together. There's 23 people, 23 residents on the floor, and there's room for about 12 maybe in the group room, maybe another 5 or 6 on the porch, maybe 4 in the milieu, and then everybody else has to eat in their rooms. I was surprised to have a roommate in, the time of COVID, but luckily she was pretty cool. The beds are only about 3 feet apart, so, and nobody wore masks except some of the staff. The staff are not easily identifiable. I would guess, about 8 of them, but some of them wore masks, some didn't, some had lanyards, some didn't. I mean, it was just kind of guessing by who was standing around looking important as to who you might ask to get in the bathroom. It was very chaotic, and I had gone in for, severe anxiety and self-harm urges, and it ramped up my anxiety even higher. So they decided the first day that I should come back to Woodstock House, and because of the COVID regulations, it took me from Monday to Friday to actually get released. But, they were going to discharge me Tuesday, just because they could see how detrimental it was to me. So, yeah.
Thank you so much for sharing. I know it's probably not easy, but I think it's incredibly valuable for DMH and for this committee to have that information of what your experience has been, the difficulty in accessing food and water and bathroom and hygiene, and the roommate issue and the delayed discharge are all just really important issues that we need to be paying attention to right now. So I really appreciate your generosity and courage in sharing.
Thank you.
Absolutely.
Yep.
May I ask a quick question?
Yeah.
First of all, I also want to say thank you. It's always really a gift when people are willing to share. My question actually is a logistical one, and do you think that you and any of the other people that you encountered in that experience would have worn a mask if they had been asked to?
I think some would. I don't know that all would have.
Thanks. That would be the answer I'd expect. Yeah.
Yes.
This is Vicki. Thank you so much for sharing this information, for coming forward. And I was wondering, just with some issues that we've been looking into as a committee, were you offered, were you informed of any of your patient rights? Were you given written material on what your rights were, how to contact the Ombudsman, Vermont Legal Aid, and a patient right?
I was handed the standard packet. I didn't read it just because I've had so many hospitalizations that it was, I've read it years ago, so I don't even look at it anymore.
Were you offered direct communication with a patient representative?
No.
And did you feel like you had access to privacy for phone calls and internet?
No. The phones in Tower 2 are like payphone style phones in the hallway. And of course you don't have your cell phones or anything. My roommate, I was often asked to leave when people were meeting with her, but, nobody would meet with me and ask her to leave. So I found that kind of odd.
I really appreciate it. Thank you for this.
Yep.
We should probably look at our agenda for next month super quickly. We'll have CSAC joining us. We have an hour and a half designated for that. We have 15 minutes designated for our recommendation letter to the commissioner. We have 20 minutes for opening business, 30 minutes for the DMH update. I'm not going in order, sorry about that. And then public comment. So there's really no room in this agenda for our ongoing business, just the way that it is. Does anyone have any concrete suggestions? Or are we good with the agenda as it is?
Well, I think there's some information that we've been requesting on an
Malika,
ongoing.
this is Kate.
Vicki and then Kate?
Yeah, this is Vicki. I think there's some information that we've been kind of asking for and looking into for a while. I think having a little bit of time just to follow up on that with DMH, and then just a quick vote on, or actually I apologize. We're going to spend a couple months with the shared drive before we vote on that. So I was mistaken in bringing that up.
Okay. Kate?
About facility thing. We didn't have any discussion about that. Would that be planned for the next meeting? Get back into that?
You broke up for just a minute. To get back into what?
Into the pure residential facility planning.
Oh yeah.
I was gonna mention that earlier. Kate, are you wanting to represent us? Do we need to vote on that? It seems to me that right.
I'm certainly in.
Were we going to send someone to that committee for the
meeting?
Okay. Well, sounds like we have a lot more data to work with, considering the Middlesex Therapeutic Community residents, than we did a month or so ago. Should we put that under? Didn't we table that to be put under an agenda item for next month anyway?
It's not on the agenda. We don't have space in the agenda as it is right now.
Okay.
Just a reminder, we do have a list of the open action items for the committee that haven't, or whether they've been addressed or not. And I think one of the things we requested last month was permission to have a representative sit in on the racial equity group that DMH has meeting biweekly, and I don't think that's been followed up on. But I know we're over time. I'm not sure how we can fit that in for next month.
Right.
Yeah.
I got feedback from that group that's currently a closed DMH group. So it's open to DMH employees only at this time.
Well, that makes it a bit of an easy answer, perhaps?
Well, yeah, that's an answer. I wonder if we can aim to, but not necessarily commit to, shortening the amount of time that we spend in discussion with CSAC. Try to end that early so we can get to some of our other business, such as the secure residential. And also, I think there'll be some work done in between meetings about some of these things as well, that we can keep each other in the loop about.
I'd be in favor of that.
Sounds good to me. I would like to know, as an action item, how much information regarding listening tour I should send to VPS, and what sort of collaboration does that committee want from me in kind of keeping VPS up to date on logistics for Central Vermont Medical Center and Vermont Psychiatric Care Hospital, maybe? Seems like that's going to be the first listening tour, right?
I can't remember off the top of my head, but Bert, do you want to maybe send an email to Dan and Ward and I about that?
Okay.
We can figure that out outside of this.
Yeah.
That sounds like a good next step. I'll be doing that with Vicki as well, concerning the patient reps at VPS. So
great. Thank you.
Thank you.
I have another
I do
meeting
too,
late
honestly. I do too.
Someone will need to motion to adjourn.
I can motion.
Seconded.
Bert here. I will motion to adjourn.
Great. Seconded by
Okay.
Dan. All in favor?
Aye.
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 Any opposed? Okay.